This is a case of a subacromial and basically at the same time just about glenohumeral injection in a 77-year-old female. She has significant rotator cuff arthropathy, which you can see by her x-ray. Here we're looking at her shoulder, but trying to find the supraspinatus tendon, which you can't see. You just see a very complex subdeltoid bursitis and joint effusion. Here is, again, this very complex subdeltoid bursa, trying to find the supraspinatus and short axis, which we cannot find here. Just the deltoid muscle going just about down to the humeral head and the greater tuberosity. Now we're starting the injection. We essentially are putting the needle right over the greater tuberosity. We're essentially just skimming right over it, and we're essentially in this subdeltoid bursa, which if you go just a little bit further, you'll be communicating with the joint. You can see the injectate filling the joint on the left side of the screen and also going into the subdeltoid bursa on the right side of the screen. So in a patient with no intervening supraspinatus tendon, you essentially can have your needle in the subdeltoid bursa and then just advance it a little bit through the capsule, and you're actually in the glenohumeral joint space. You can essentially inject both those spaces with one needle stick. Here we're going to go over some of the relevant shoulder anatomy regarding this injection, which again we can do both in one needle stick, the subdeltoid bursa as well as the glenohumeral joint. You can see the deltoid muscle, the biceps muscle, as well as the subscapularis muscle. Now we're making the deltoid muscle translucent, and this is essentially just a fascial covering of the muscle that we left. And now we remove that. You can see the underlying rotator cuff as well as the coracohumeral ligament, as well as the transverse humeral ligament, which keeps the biceps tendon snug within the bicipital groove. Now we're adding the subdeltoid bursa. You can appreciate how broad this bursa is, and we're trying to look at this bursa from a bird's eye perspective, which you can appreciate here. And if someone has a hooked acromion, you can imagine how that would impinge on the bursa and perhaps cause some bursitis. And here's an interesting view of the coracoclavicular ligament. You can see the conoid and trapezoid components. Good view of the supraspinatus muscle as well. And now we're rotating even further, and we can see the back of the scapula. You can also see the humeral shaft. You can see the underbelly of the brachialis muscle as well as the biceps brachii muscle long head. Again, you can appreciate the subdeltoid bursa, and you can appreciate essentially how much of the rotator cuff is covered by the subdeltoid bursa. And now we're rotating again, and this is more of a sagittal view essentially of the shoulder. Here is this patient's subdeltoid bursa. We just made it a little bit enlarged, and now we're actually showing what this patient had in terms of a complete supraspinatus tear, where there is no supraspinatus tendon overlying the capsule and the superior glenohumeral ligament, as the supraspinatus tendon essentially retracted into the supraspinatus fossa. And that's how you get a high riding humeral head in rotator cuff arthropathy. Now we're putting back the subdeltoid bursa, which is quite enlarged and complex in this patient. And this is the essentially probe position. This is an in-plane approach, and here we are just getting the needle within the subdeltoid bursa and injecting, and then we advance the needle further through the capsule, and then we continue with our injection, and we can actually inject the glenohumeral joint space again through one needle stick.